First of all, thank you, Sanjit, for giving me this difficult topic. You know, it's like uh, when he gave me this topic, I was wondering whether it is a question or a statement. It is important to measure gastric residual volume. So I was wondering, what should I be talking about? And then I said, let me take it as a statement. Amongst us, there will be many with yeses and nos. And today I'm here to argue and say that it is important to measure gastric residual volume. So let's look at a little bit of history. I know I have just 12 minutes to talk, but when did all this start and why? So the practice of aspirating the GRV actually mysteriously appeared in one of the textbooks of the nursing. And nobody really knew when did all this start. And it became one of the feeding modality and it became a standard of practice. So it's really difficult to understand when and why it started in clinical practice. Also, we all know what gastric residual volume is. That's GRV, and it is the amount of gastric content that is in our stomach at a single point of time. My dear friend would argue and say that we all have GRV, don't we? We have chyme with us at all times. And somebody, of course, right now, there's no lunch for you, so your GRV would be pretty low. But anybody who has eaten a meal would have a higher GRV than anybody else. But are we talking today about you, me, or us? No, we are talking about critically ill patients and their GRV. So, do you agree with me that prevention is the main goal when caring for the patients who are at high risk of aspiration? Also, evidence shows that one of the principal precautionary measures of aspiration is so many other things, including position or other measures such as absence of reflexes or assessing their different measurements. Now, identifying these patients for delayed stomach emptying is a most important aspect where GRV is concerned. So, the risk of aspiration for critically ill patient, and that's when we actually do the GRV measures. How is it done? Very simple technique. By actually aspirating or removing some of the contents from the stomach and measuring it. So if it is safe, this content is reinserted and feeding continues. This is the normal process that happens. What happens when it is an unsafe measure? The content is discarded and the feeding is held. Now, the goal of monitoring GRV is to detect feeding intolerance as a result of preventing vomiting, regurgitation, aspiration, and developing, of course, aspiration pneumonia. How did this start and how suddenly people started talking about GRV? We didn't really talk about GRV so much when we studied 25 years ago. But it so happened that a paper was published, and in which, this is not an Indian paper, there were about 2,000 or so nurses who were asked about GRV. And about 97% of them said that they do check GRV, and some of them said that they check after every 4 hours. And why did the bodies take up the matter of GRV so seriously is because of this. There was variation in how people actually measured GRV. Some say that they measure, 24% said that they measure GRV of 100 ml and they stopped feeding the patient. Some other nurses, they say that when the GRV was about 200 ml, they stopped feeding. Some other nurses said when it is 250 and some others said when it is 500. So where is the consistency in actually measuring the GRV? And that's when the topic of what should be done for GRV cropped up in 2016. So there is a lack of agreement of what constitutes a significant GRV, and this practice has to be streamlined. Hence, the three bodies had something to say. The ASPEN, the Society of Critical Care Medicine, and the ACG. They all said that let's look at what this GRV is, how it should be measured, how much it should be measured, and what should be the guidelines for the critical care nurses and the other team members to follow. Because when there is cessation of feeding, it leads to malnutrition because there is calorie deficit, protein deficit, and we know what are the consequences of malnutrition. So, detection of feeding intolerance and prevention of aspiration and pneumonia. These are the two major aims of GRV measure. Now, is it that measuring GRV will improve the outcome of the patient? Not necessarily so. Although in 2016, all the three bodies did say that they do not recommend routine monitoring of the GRV for ICU patients and patients who are receiving enteral nutrition. So they did use the word do not monitor routinely. However, holding feedings of GRV greater than 500 ml should be avoided if only there is a sign of intolerance and not otherwise, like vomiting, abdominal pain. So patients receiving an enteral nutrition should be assessed for a risk of aspiration, and there should be various steps taken to reduce aspiration and aspiration pneumonia. So monitoring intolerance and adequacy of EN, how should it be done? It's not only a single aspect of GRV, but there are various other aspects involved in it. It could be GI intolerance, it could be checking out input-output, discomfort of the patient, vomiting, diarrhea, and various other ways in which you actually find out whether the patient is at risk of aspiration or any other GI intolerance. So inappropriate cessation of enteral nutrition should be avoided. Ordering an NBM status for a patient unnecessarily only because of a GRV should be avoided. And GRV should not be used as a part of routine care to monitor ICU patients and those receiving in absence of any other signs and symptoms. However, when you look at the guidelines a little bit more closely, you will find that the quality of evidence is pretty low. And hence, these days, there are also other modern means of checking GRV. There's a modern technologies which can be adopted by ICUs so that they can monitor a sensor-based GRV status monitoring at real-time reflexes, and detections are available today. And without probably this real-time monitoring of reflexes, even periodic functions of 4 hours of interval may miss the random reflux check. To end, I would say that every hospital and institution should have their policy for GRV. It should be penned down and it should be written down. For GRV greater than 500 ml, consider prokinetic agents, consider post-pyrolic feeding if required, or consider a low feeding rate. Also for GRV between 250 to 500 ml, what can be done? You can use it, reuse it, reinsert it, and discard the remaining. For GRV about 250 ml, reinsert all of it and continue the feeding. Thank you.
So I was just asking the moderator, do I have to go ahead because she's agreed with me? I mean, last slides are exactly my slides. So there's a consensus. I should not be giving my talk anymore. So let's start with, as she said, is it a statement? So if you see, I have written in bold letters, it makes no sense. GRV. So when we talk on it, everyone knows nutrition is important, and when it's basically in healthcare patient, and this whole topic and boot camp has been carried out because we know critically ill patients are very important and we need to feed them. Especially when they are on mechanical ventilation, underfeeding is more of a problem. Everyone has a Riles tube inside, they are not able to eat, so obviously the enteral nutrition has to go on. And patients with enteral nutrition are at great risk of malnutrition, and it was very well pointed out by the two eminent dietitians with me. Bhakti very clearly said it. Okay, it's the frequent interruptions which are the problem in the enteral feedings, and I think she agrees to it. So I was very happy when I was listening to it, quite elated. Okay, yeah, someone who agrees with me, and we all know the frequent interruptions are because when we measure so-called high GRVs, and I don't know what that high is, we'll be coming to that again, and it increases the risk of, assumption is it increases the risk of aspiration and the ventilator-associated pneumonia, which I strongly believe is an assumption, it's a belief, and I'll clear that out in my future slides as well. So if you look, all this high marked, red marked as like high elevated GRV, and if you see, it's very clearly had a firm place in the recommendation of critical care. It's not there anymore. And it was the most traditional, as she very clearly said. This is why I said, do have to go ahead. She very clearly said it came up with the nurses, and she also used the word, it's a tradition which is being used, and it's a tradition itself which is being used. And she clearly said 97 of the nurses reported, and if you see, the different values. You remember all this, 200, 250, 25% of 150 ml, and 12.6% GRVs are up to 500 ml. So there were no consensus over there, and still there are no consensus over there. So when it comes to the world, when it comes to India, we are all cultured, we all know. So it's many people around, ethnicity around, and we also believe in the tradition. And this is where the tradition in the ICU also gets followed. ICU has a culture where we follow a culture of blood culture. And this is where the use of GRVs monitoring is often based on the tradition rather than evidence, which often guides the critical care nurses in managing enteral feeding with unnecessary interruptions of enteral nutrition, and this is where we end up into the problem of underfeeding our patients. So here, we all know it's more of a tradition, and we are here to win over the tradition because evolution is the system. We have to evolve, and obviously we'll come up with this. So I need all you to applaud for this because we are here to change. Yeah, thank you. So, methods of measuring GRV, I think this was quite of philosophical. Now, we'll come to the scientific approach. There are two methods, we all know. One is by pulling it. So, when it's a night shift, 4 a.m., nurse is just pulling it. Maybe 100, 10, 20 came up, she'll say 10, 20 ml. So, fresh nurses come at 8 a.m., she'll pull it. She'll also adjust her Riles tube. She'll pull on around 400 ml. Sir, 400 ml aaya. So, around 4 घंटा पहले 10 ml था, अभी 400 ml आया. So this is basically no one to be blamed. There are too many areas. It's a type of tube, length of tube, diameter of tube, viscosity, patient related, what exactly the position of the patient is, intra-abdominal pressure is, and investigator related as well, individual preferences, how I do have to pull it with the 10 ml syringe, with the 50 ml syringe, with the 20 ml syringe. So it will vary from the patient to patient in the same patient itself. And what is large? Maybe for me, large is 30 ml. Sanjit will say 90, and Chandru will say 180 is too small for me as well. So we exactly don't know what the large is. How high is too high? We are not aware of it. Problem is what to do if we are too high. So maybe I'll go home if I'm too high. What Bala would do? Bala will not go home. He is a strict wife around. So he'll say, sir, मैं आपके साथ ही रह जाता हूँ. Maybe next morning I'll go home. So when it's too high, some sister will push in. Some sister will say, nahin, let's discard it. We don't know what is to be done with it. So we exactly don't know what the too high is and what is to be done. So this is where the problem is. And you see this was quite eye-opener. So in the same patient, the tube size is different. You will pull different kind of GRVs. So it's 1.2 to 1.7 times more when the tube size changes from 10 to 14 and 18 French. So I think there's a problem. We exactly don't know what the high is. It keeps us spinning, and drunk is plus high. So as she very clearly said, normally maybe my GI system will secrete 1 liter. When I'm drunken, when I'm feeding more, it will secrete maybe around 5 to 9 liters. So when you're drunk, you're more high. So when you're feeding your patients, obviously there'll be high residual volume which will be coming up. So this is what it says. So at least they studied, this was the aspiration which was studied in one of the studies where they used a pepsin. They said at least one evidence, pneumonia was defined, so at least one patient who had a pneumonia. What they found is 120 to 82 patients who were fed in the stomach were included in the analysis to determine. So there was no significant difference found in GRV and the GRV in high and low aspiration and the pneumonia. So what they studied was the pneumonia, and they related the pneumonia to the GRV. So there was no relation to the high and low GRV in those patients. And again, there are too many studies to publish. So this is the impact of not measuring GI system. So this was a European in pediatric, where you can see the punchline is less of time. So punchline is not measuring GRV did not increase vomiting, ventilator-associated pneumonia, or necrotizing enterocolitis, which is a main concern. So we have an evidence here. Furthermore, it showed measuring, no, in patients whom we don't measure GRE, maybe there was no delivery, there was better delivery of the enteral feeding because there was no interruption, and those patients are better fed. So again, this is one more. Regina did a trial. There was no development of VAP or new infections or length of ICU stays in mechanically ventilated patients when GRV was not monitored. But what it would do is, it would allow critical care nurses to focus more on interventions which are important rather than just sucking it and deciding whether what is to be given, what is the amount. And so another one came in, these was another Nutria which says 449 patients mechanically ventilated early nutrition. Again they said that primary outcome was VAP, which was studied at 90, but there was no difference when it was compared to the intervention group where there was no GRV to be measured. So these are the so many studies. I mean, I can just, where there was no difference in the mortality, no difference in the VAP when it was as compared. So this is what we believe. It causes more of regurgitation, it causes more of pneumonia or VAP, but actually it is not true when it comes to the study. And the background is, so I just wanted to put in one more. So this was the meta-analysis because we thought of so many studies around. So even the meta-analysis didn't prove it, where they included around 900 patients. So this is one of the cohort studies around approximately 2,000 patients, which is exactly the volume as Dr. Pandit was saying. So this was large GRV and GI symptoms. So what exactly the crux is, patients who were more sick, patients who were more mechanically ventilated, patients who had high polytrauma, traumatic brain injury or the septic shock, those were the patients who had more of GRV. So it's other way around. Sick patients have high GRV. It's not high GRV where we don't monitor and push in causes pneumonia. It's other way around. VAP will have more GRV. So we need to understand the disease which is the problem. So I have explained you all the points saying we don't know what the high is. We don't know what exactly is to be done when you are high. We don't know. We are wasting our nurses' time, and obviously there's no mortality difference, there's no pneumonia difference, there's no length of stay difference, but still I know it's a time of rebuttal, I have to listen to her, what exactly is to be done, but we'll go as per the process, what are the pros and cons, what are the logical discussions around.
5 comments. So, do you mean that we should throw GRV in the dustbin?
Yes, the way we measuring it, yes. What are the other ways around are the more radiological markers as your slide presented. And our
do you mean to say after 2016, probably you will go into the committee and tell all of them you get a side now?
I mean, anyone who is working with me since 2016, they would know we are not been measuring GRV in my OEC.
Correct.
Yeah,
so, but as long as most of my other friends also said that we'll go by the guidelines, we still go by the guidelines.
Guidelines are to guide. I mean, we have the logics here. So as it was experience versus evidence based. So when it comes to the guidelines, are always there to guide. So when we clearly know something is not working, it's not working, and we have enough evidence to say this is not working.
Point taken.
There's a lot of heterogeneity in measuring. To measure or not to measure, because it's not an exact science here at this point of time. There's a spectrum, and there is no specific standard practice which says definitively that this works or this does not work. So it just may be that we are not adequately developed enough, or we don't have adequate information at this point of time to say that this works or not works. As Dr. Pandit said, that we've not had enough data to clearly go one way or the other. And it is still very subjective. There are various factors that makes one, the keyword is vomit. All of us are healthy individuals to a point, and your GI motility, perfusion, volumes, etc. depends, and it is varies as per your personal factors. Now, a person who is sick, who's really sick, and who actually needs input from your healthcare givers because they themselves cannot decide for themselves. So there is the question. Those are the subgroup where we actually need to know, and probably in the future we have so many devices available for every small thing. I was just hypothetically thinking that we started working with ventilators where there was NAVA ventilators. So maybe in future when we have a very, very sick patient, we may have a sensor like a reflux sensor device, and we actually so we actually use it. Maybe it's still nascent, it's too expensive, and we may not be actually using it, and they may help in that.
So I think the message is very clear from all the debates, but I must say Dr. Sanjeet very smartly put the dietitians onto topics which were not something that we practice, and I think kudos to all of you for the justification and for making it so interesting. And what is really good or nice about this event is that we see the doctors talking what we talk every day. So I think that's what is the message today. And I think with that we can close this session, but I'm sure you'll have your comments.
It's been a great. Oh, is there a doubt here? Okay, right. Can,
Sir, one simple question is there. Sir, in routine our ICU practice, sir, we instruct the staff to every 2 hourly there is RT aspiration. Go for the RT aspiration. Sir, is there no role according to this debate?
is this wrong?
Is this any role of RT aspiration?
Is there any role?
Yes, sir.
So it's the same. So you know, it is a practice that requires a lot of change. This is an inertia that has been there, and in many number of ICUs where they still monitor gastric esophageal volumes. I think probably the answer would be to have a classification for the patient that actually requires to be monitored. I mean, by science. I mean, that's what I feel. So we'll have a number of patients and maybe pick out a group of patients in which we'll probably do that.
Yeah, actually I was expecting her to come up with that. I mean, she didn't come up with that. So that was actually a point of discussion. So if you see all those studies which have been carried out now, all of those in the medically ill patients. I mean, it's 80 to 85% on the medically ill patients. So there's a subgroup, surgical patients, where exactly we don't know what is being done. So why those are not included in those studies was basically surgeons don't agree sometimes to do their purpose, and still they wait for the bowel sounds to come in. So that was one of the reasons. But by and large, as he very clearly said, Sanjay, it was an inertia. So when the guidelines came in 2016, if you believe me, we started that way. We used to monitor 4 hourly, 6 hourly.
Yes.
Then we came up to 8 hourly, 12 hourly, and we realized, then we did it 24 hourly. I mean, we used to do it just, I mean, there's a gap of around 2 to 6 where we don't feed our patients in our ICU. And before starting at 6 a.m. we used to measure it. So we realized that there's hardly any fluid. I mean, nothing comes out, just 10 or 20 ml. And if I was doing it 2 hourly, 4 hourly, always it was 400 ml, 300 ml. So there's a delayed gastric emptying. There's no regurg as such. So at least your food is getting absorbed. So now we just don't do it at all. So we need to build a practice and develop it and gain confidence over it by prolonging your duration and then ultimately coming up to it.
Yes, sir. Now it means like it's absolute. But sir, apart from that, what is the chances of if there is a patient is having a residue volume, and then what is the chances of aspiration?
So, whatever studies I very clearly said, I mean, I did not go into the details of it. I had few slides where it was very clearly what they were looking, when there was no, in the intervention group, when there was no GRV, they were measuring. So what they were looking into is, they were looking into the girth of the abdomen, and also they were looking into the vomiting. So what is vomiting in mechanical ventilator? When you suction it, you can feel something is coming out. So even in those set of patients, they did not find any increase. There was a regurgitation, but they did not find any increase in the VAP when it comes to the comparison in between the two groups. Yeah.
That's so at least the studies have gone on to say that measuring gastric residual volume, as of now, the evidence does go against the measurement of gastric residual volume. Moreover, I strongly believe, on a practical note, whatever you take out may also be left and thrown away, which would contribute to iatrogenic underfeeding in the long run most often. Thank you very much to all 3 of you all 4 of you all.